Hello, friends. Good morning. So, thank you for joining on this Tuesday. So, Happy New Year to everybody. Yesterday, we had our first VMR of the new year. It was an amazing pulmonary and critical care medicine case, brilliantly discussed. So, I suggest all of you to take a look at it if you didn't get a chance. And today, I have pleasure to be with Dr. Singh, who is going to discuss a case with me today. We will try to run through a nice case, discuss our thought process, and we'll also try to incorporate the thinking which goes behind the case in the chat. And as always, I say that the collective power is way, way greater than the individual power. So if you have some thoughts, then do share it in the chat. And it always helps to refine our thinking process, get to the diagnosis more efficiently, and manage the condition more effectively. So thank you for joining us again. And I will pass the mic to Dr. Singh to introduce himself, and then we'll pass the mic to the rest of the team members. Thank you.
Thank you, Keithan, for that introduction. It's an absolute pleasure to be back on VMR, especially the start of a new year. So happy New Year, everybody. Lots and lots of good luck and positive energy for all of you joining today. And hopefully we can all improve our clinical reasoning skills going forth this year. So I'm absolutely stoked to be here with Keithan. It's like going back, I think, before he started internship, and we would routinely co-discuss cases here, or even on WhatsApp, he'd send me cases and we're like, okay, what's going on with this case? So kind of missed that. And but it's great to at least have him for 2 weeks of his vacation to at least learn from him. He has lots and lots of great pearls and teaching that he at least shares with us on a daily basis. Again, I'm going to put out there, if anybody has a case, feel free to share it with us today. And we'll see who else is there. I think, Deborah, how have you been? How's North Carolina? Is it North or South Carolina that you're at?
Hi, everyone. Yeah, good. Happy New Year to everyone. I am in North Carolina, Charlotte now, and tomorrow flying back to Brazil. My brother will graduate from med school. And yeah, I'm super excited and excited for being here today. Let's start a great year of a lot of learning.
Awesome. Yeah, how's the weather? It's better, right? It warmed up a bit.
It's better, so much better.
It's back in the 50s and 60s. So yeah, I'm sure you would appreciate that. How have you been, Yasmin, Aya?
I have been studying for step 2 now, and Texas right now is again getting a little bit more warmer. So we're good. What about you, Aya?
I escaped the cold and the storm in the Midwest, and I'm in Dubai visiting my parents. So it's been nice over New Year's.
Incredible, yeah. Okay. I've always seen Dubai on pictures and things like that, but definitely a place I would like to visit in the near future. David, how you been?
Good. I'm in Madrid now. Tomorrow studying the residence again. So let's see how is this year.
Awesome. And Hans, how have you been?
Well, I'm okay. I'm visiting my mom, and yes, they had a cold December turning into almost 20 degrees. That would be, I think, 60s in some area in Germany, which is way too warm. And the average in 2022, which was the warmest on record, was 2.4 degrees above the long-term average. So unless our politicians speed up, we'll end up with 3 degrees on average. I don't know whether our ecosystems will survive this. It's very unusual. We should have snow over here.
Yeah, we actually haven't had snow, but I know Buffalo, north of here, and Canada, Ontario had record snowfall. So something I don't miss. Omaima, how have you been?
Hey Ravi, I'm good. We don't have holidays for New Year's in Morocco, but I had a few days off, and about the weather, it was very cold, as you can see. It's very cold for North Africa.
Really? Wow.
Yeah.
But I absolutely enjoyed watching Morocco in the World Cup. So
yes,
great
we
team.
did too. We're
Yeah.
still high on that joy.
Fascinating, representing North Africa. So great,
Thank you.
great team. And I know a lot of their players are being vied for amongst a lot of the European clubs. So we look forward to seeing them, not just in France or PSG, but some of the other teams.
Champions League, yes.
Yep.
Hopefully.
All right. I think we have a backup case because there's nobody's prepared one. So I'm going to lean on. Is it Deborah? You had the case?
I do.
Okay. All right. Well, we can deploy the whiteboard and get going. Keaton, you want to tackle the first aliquot?
Sure, sounds good.
So the chief concern is leg pain. Do you want more information or can I stop here?
Oh, I think that's interesting. We do respiratory system, cardiac system, but legs. Let's start with the legs. What do you think, Ethan?
Yeah, so I think this is something which is not very unusual in the day-to-day life, whether you are working in the ER or whether you are working on the floors. You will often see the patients who come in with leg pain. So first and foremost thing is to assess the acuity of the situation. Like if the patient tells you that the pain is definitely unbearable and you can see that there are some signs of injury, the patient was a victim of the motor vehicular collision, then you need to triage them earlier. You need to immediately get the orthopedics on the board. You immediately need to get the vascular surgeons on the board and evaluate accordingly. And then the second thing would be to find out whether the symptoms are unilateral or whether they are bilateral. And once you have judged whether it's unilateral or bilateral, then having an anatomic approach can help us. Whether the problem is in the skin, whether the problem is in the subcutaneous tissue, then the fascia, then the muscles, then the bones and bone marrow, and finally the blood vessels and the nerves which are supplying the leg. Because all of these can give you the leg pain. The flavors in which you get the leg pain can be different depending on which structures are involved, but having an anatomic approach is important so that we don't miss any particular entity. So as we are talking about the acute conditions initially, the first and foremost thing will be to rule out whether there is a vascular problem, whether there is critical limb ischemia, maybe from the atheroembolism or acute vessel occlusion of the blood vessels. And also it will be important to find out that where we are localizing. Is it a femoral vessel occlusion? Is it a popliteal occlusion? Is it a distal, like tibial or dorsalis pedis occlusion? Because if it's the proximal occlusion, then the things are more critical. Then on the venous side as well, we would like to know whether we have deep venous thrombosis or in the superficial venous system, whether there is thrombophlebitis, which is causing or contributing to the leg pain. And why the vascular problem is important, because it can cause what is known as compartment syndrome. And we know that many people who have trauma, some people who have, let's say, fasciitis, necrotizing fasciitis and things like that, they can get the increased compartmental pressure. And because of the ischemia, the pain can be unbearable and it's a critical situation because it can lead to rhabdomyolysis. So that's the vascular problem. Talking to other critical conditions. So the skin part is very important, whether we are dealing with cellulitis, disseminated infection like necrotizing fasciitis, erysipelas, things like that, that will be important to find out. So looking at the skin as well, whether there is any rash on the skin, there are any petechia, any purpuric lesions, any break in the skin, which can guide us that what could be contributing to the leg pain. And the bone part, we have to find out whether we are not dealing with osteomyelitis or septic arthritis of the nearby joints, maybe ankle joint or maybe the knee joint. And lastly, the muscle part, whether we are dealing with infectious myositis or some sort of autoimmune myositis and other like drug-induced pathologies as well. So with this anatomic approach, we can move ahead. And as we get more HPI, we can kind of zoom in. So Dr. Singh, what do you think? How we can refine this process more?
That's an absolutely outstanding process. I think you went through and taught the audience a great approach, and I love the anatomic approach. That definitely crossed my mind. And 2 points to add to your fascinating walkthrough of potential diseases. Yeah, I would start with what could be life-threatening in this case. Number 2, I like what Austin mentioned, that there's maybe referred pain. Maybe there's something maybe above the leg, maybe from the abdomen, maybe from the foot. Could there be referred pain? I'll probably add more. I was going to say 2 points, but 3, is this part of a systemic disease? So occasionally some things that may be further up in the body may trigger something in the leg. So something like maybe, like you mentioned, venous thrombosis, maybe inflammation triggering an episode of gout. So certain things that could trigger leg pain. I think number 4 or 5, I wouldn't trivialize. Many times, if I look at it from a clinical standpoint, we get many calls to see patients on the floor with leg pain. So I think utilizing Kirtan's approach while you're walking to go see the patient and address the leg pain, examining the leg, and also he highlighted a key feature. Is it unilateral or bilateral? So you want to compare the leg that's affected to the other leg and see if there's any change. If there's, like you mentioned, edema, is there discoloration? Is there a rash? Is there a ulcer or a wound? So looking, I guess, observing the legs before you start touching. A lot of times we go grab the leg and the patient screams out that it's painful. We have to be very careful. And even more important, ask the patient for permission before you start touching the leg. So it's always important to make them aware that you're about to perform a maneuver on the leg. Also, you want to highlight the history. So what happened before this? So again, highlighting the trauma. Was there a fall, injury? Was there impact or anything like that? So a couple of things to just add to Keithan's incredible walkthrough. And again, it's something we're not always discussing here. So I really like this chief complaint, and it definitely is something that can help or I could learn from whilst we dissect this case, because it's commonly seen on the floors. Back to you, Deborah.
Hi, great discussion, everyone. Okay, going for more information. The pain has been for 8 weeks and gets worse with the movement and alleviated when the keeping left leg still. And I didn't say the age, I'm sorry. It's a 46 years old female. And has been having some weight loss, 10 pounds, and exertional dyspnea. So she has like a past medical history of lytic bone lesions and had done like 4 weeks before a CT of the cervical, thoracic, and lumbar spine and left lower extremity, and was notable for lytic lesions involving the left ischium, femoral head, L4 and L5 vertebrae, and mediastinal adenopathy, and had like a CT guide biopsy in L4 and was not diagnosed for infection, fungal mycosis, or malignancy. And the lesions was felt to be likely like multiple myeloma, but the patient was discharged from oncology, and then he turned now with this pain. And another past medical history is AIDS. She has a viral load undetectable and a CD4 count of 116. No other defining illness, no clear reason for persisting low CD4 with persistent suppressed viral load. And take the medication, antiretroviral therapy. I don't know if I know how to speak. Ifavirenz and tricitabine and tenofovir. And the patient doesn't have any recent travel, no allergy, no alcohol, and no drugs, and no family history.
And Deborah, just one point of clarification, that the pain was in both the legs, right?
It was, yeah.
Okay, and
in movement.
Sure, and it was alleviated by rest and worsened by movement.
Yeah, exactly.
Sure. Thank you.
Yeah.
Dr. Singh, you wanna go first?
Sure. So one thing that really rang a bell or stood out to me was this osteolytic bone lesion. So at this point, I'm not sure if it's something incidental. Is it a detractor? But you know what? I'm going to go down this rabbit hole a bit. So Deborah mentioned something key. A system one thinking always sort of will trigger, is this a malignancy? So myeloma may be one of them. Or are we just dealing with something that could be benign? So it could be simple bone cyst, that could be a play. You could have other causes like a Brown's tumor that may be causing this. And then osteochondrome could also be causing this. I think Ketan mentioned infections. Infections usually may not have this sort of morphology. We sort of look for osteomyelitis. We tend to see on this, the imaging, the Codman's triangle and so on. I don't think it would have morphology that would be similar to this. But definitely metastatic lesions, myeloma, there's a whole number of different tumors that could manifest for like this, primary bone tumors or metastatic lesions to the bones. And could this be an explanation for this patient's pain? I'm not sure at this point, but definitely something to put on our radar screen and definitely reflect back on as we get more aliquots. And the CT-guided biopsy did not show infection, but then again, biopsies can miss. They're not foolproof. So can we maybe discard the possible infection as a cause of this? I think it's kind of too early, maybe premature at this point, but definitely keep it in the running. Now with AIDS, I'm going to let Ketan maybe reflect on this. How does HIV change the landscape of this complaint of leg pain? Back to you, Ketan.
Yeah, thank you for laying that nice framework, Dr. Singh. So firstly, I was thinking about that, what can explain the pain which we have in the leg? Because when we try to find out that, okay, it is coming from the bone, or is it coming from the blood vessels or from the nerves, then we can try to zoom in. So I think in our case, since the CT scan showed that there is multiple lytic lesions in the vertebral column, there is also involvement of the femoral head. So that kind of, adds to the suspicion that, well, maybe indeed the pain is stemming from the bony involvement of the lower extremities, and maybe the patient even has impingement of the radicular nerves in the spinal cord because of the way the vertebral column is involved. And maybe, once we get the MRI, we can get the better idea whether there are multiple level nerve root compressions which can explain the pain which is present in the leg as well. But just on the side note, we would also like to make sure that we are not missing any paraneoplastic neuropathies or infectious neuropathies if the process which we have is indeed either neoplastic or, let's say, infectious, because things like myeloma, which can cause lytic lesions, often can cause neuropathies because of the way the antibodies are formed. For example, you can get anti-MAG neuropathy sometimes in people who have myelomas, and lots of IgM and IgG dependent neuropathies. So would also keep that at the back of the mind. And regarding the lymphadenopathy and HIV, it's really interesting because we often see that people have HIV, and then once you have the HIV, that Occam's razor, which is Hickham's dictum thing, comes into the play, that you cannot really say that, well, this is the one diagnosis which explains everything, because with HIV, things change rapidly. You can have numerous infections going on, numerous malignancies like hematologic malignancies, which people are at increased risk for, which can also explain the other findings. The one important thing is that usually myeloma doesn't tend to cause lymphadenopathy. That is something which is very unique for myeloma. It is one of those neoplasms which doesn't cause lymphadenopathy. So given the fact that we had mediastinal lymphadenopathy, and if it's real lymphadenopathy, like not just benign finding, then it makes me think that what if it's not just myeloma and maybe something else? So we are talking about the lytic bone lesions, then what malignancies can usually cause that? So classically, like squamous cell lung cancer, then metastatic renal cell carcinoma, colorectal cancer, gastric cancer, thyroid cancers, and even melanoma can cause it. Usually prostate and things like small cell lung cancer are more blastic, but in rare cases, they can even cause lytic lesions. So we would think about that. And with lymphadenopathy, it's also important to think about granulomatous disorders, whether it's infection or autoimmune. So like sarcoidosis is something which can classically present with mediastinal lymphadenopathy, can even cause lytic bone lesions. So given the fact that patient is in that age group, patient is a lady, so it can happen that she might have sarcoidosis. And given the epidemiology, we would also think about, could this be tuberculosis, endemic mycosis, things like brucellosis, coccidiomycosis, then Burkholderia, other infections which are granulomatous in nature. With AIDS part, it's really tricky because we know that AIDS can increase the susceptibility to lymphomas like Hodgkin's lymphoma, various non-Hodgkin's lymphoma, EBV mediated, HHV-8 mediated sarcomas and stuff, all of which can affect the bone. And in the right context, they can cause lytic lesions, although this may not be the classic presentation of that. So that is also something that I'm keeping at the back of my mind, that how can, HIV turn the things around. So that would be my approach as of now. And I hope that with the physical examination findings, we can get more data, whether the reflexes are altered, which can guide us towards the neuropathic process, or whether it's more localized tenderness, which can cement the suspicion for the localized bone involvement contributing to the pain.
Absolutely great walkthrough there, Kirtan. I'm going to go back to the HPI and just highlight this. They put it in red, but 10-pound weight loss. Now thinking back, if I now rattle off a list, definitely malignancy is at the top of my list here. So leg pain, lytic bone lesions, weight loss, and then mediastinal lymphadenopathy. So again, we went through a number of malignancies. Epidemiologically at this age, what kind of malignancies? We haven't had social history. Like, is there any occupational exposures or any habits that may increase the patient's likelihood of having lung cancer or any of the other cancers that we've discussed? And then secondary, could there be infection? So there is a significant amount of possible inflammation here, which could be from infection or malignancy here. But I think at this point we'll get some more information in the next aliquot from Deborah, and that may move the needle towards the domain that we need to invest in. So back to you, Deborah.
Okay, going for the vital signs, the temperature was 98.6 Fahrenheit, and all the vital signs were normal. The patient shows chronic wheal with acutely uncomfortable. For the pulmonary, had basilar crackles. In the neural exam, 2 of 5 left lower extremity trench, and had like some papulosquamosis eruptions in the glabella. And I'll wait for the whiteboard. And the rest was everything normal. And the lab had a white bone self of 2,100. The normal, it's like between 4,011, and the patient had lymphopenia. It's okay, don't worry, you're doing great. Yeah, the patient had some lymphopenia, and then all the rest, everything, the chemistry was all normal. And they did like a serology for histoplasmosis and blastomycosis that was negative. Negative blonde and orange cultures. And it was repeated the CT of the lower extremity that showed again the lytic lesion involving the left ischium that was in the previous CT. I can give a little bit more information, then the next aliquot I give the result, I give the diagnosis.
I think we can stop here. There's a wealth of information here. Kirtan, you want to take a stab at this?
Sure. So, Dr. Singh, I was thinking that maybe I can discuss the papillosquamous eruptions part, and then maybe you can guide us that how we can involve the lab findings into our thought process. So now dermatology is something which is very fascinating and which always excites me and keeps on motivating me to study more and more, because oftentimes we neglect the cutaneous findings, and as it happens that we might read like 10 pages on one topic, But if we don't recognize how to incorporate the skin process into our thought process, then we miss the diagnosis. And just by knowing that skin process, maybe we'll get the diagnosis. So it's like, a cheat code. So papillosquamous eruptions definitely is something that we should think about. So thinking broadly, that what can cause skin eruptions? Is it infection? Is it autoimmune disease? Is it malignancy? Or is it some sort of infiltrative disorders? So firstly, talking about infections, and what kind of infection can cause such kind of eruptions? Now, as of now, we just know that those are papillosquamous eruptions. We don't know more details, whether they are itchy in nature, whether they are erythematous, whether it's like oozing something, and where exactly is the lesion. But Deborah told us that it's something around the nose and near the glabellar region. At least that's what we know. So what kind of infections can cause that? So all the endemic mycosis, including granulomatous infections like tuberculosis, can often cause cutaneous eruptions. Like you have what is known as lupus vulgaris, which can happen to people in tuberculosis, not necessarily on the face, but often it can present with papillosquamous eruptions. So we would think about that. Then some syphilitic infections like a Treponema pallidum can cause presentation like this. Sometimes mucocutaneous leishmaniasis, which is one of those sort of infection which can cause infiltration into the skin, can also cause this. And the patient had lymphopenia, the patient also had bone lesions. Sometimes leishmaniasis can fit nicely into that picture. Brucellosis is also known to cause skin lesions, so you should think about that infection as well. Talking about autoimmune and some infiltrative conditions, so we were referring to the sarcoidosis initially, that how it can cause lytic lesions, how it can cause adenopathy. And sarcoidosis also causes eruptions on the face. In fact, the pattern in which sarcoidosis causes these lesions is known as lupus pernio. Usually, those are kind of violaceous lesions, very similar to how you get in people who have Kaposi's sarcoma and people who have Bartonella-Hensley related bacillary angiomatosis, both of infections which are common in people with HIV. So that is how lupus pernio looks, kind of jelly-like lesion on the skin because of the granulomatous environment. So that is one way which we could link that. And I would also think about some drug-related eruptions usually, but since it is localized and these drugs which patient is taking is not classic for that, so we are less concerned about that. In infiltrative condition, the last thing which I would like to mention is the histiocytic disorders. Because when we think about the lytic bone lesions and when we think about the cutaneous disorder, then things like Langerhans cell histiocytosis often comes to mind. And often we think that that is a disorder which affects only the pediatric population, but many times it comes in the adult age group and sometimes even in people who are beyond 50 years of age. And with the cutaneous eruptions and bone lesions, we should always think about Langerhans cell histiocytosis. So starting from some infections, including leprosy, leishmaniasis, tuberculosis, all the granulomatous infection, then moving to some HIV-related infections and infiltrative disorders, like Kaposi sarcomas and lymphomas, NK T-cell lymphomas, things like that. And finally, autoimmune disorders and infiltrative disorders. So that is how we can approach that. And let's see what Dr. Singh has to teach us, that how we can move further progress in this case.
I don't think I have much more to teach, my friend. You've done a wonderful approach. There's so many possibilities here. My mind is buzzing which one of those to really drop or anchor on to try and figure out what's going on with this patient. So there's a multitude of possibilities. So I'm going to look at this this lymphocytopenia. It's kind of interesting. The first thing that kind of comes to mind is viral phenomena. So when you have a low lymphocyte count, especially with this degree of leukocytosis, you can have any number of viruses that can cause this. Namely, COVID was a big one that we identified this pattern. In fact, I had a patient with no symptoms, maybe just some diarrhea, have lymphocytopenia, and we were able to figure out this could be COVID early on during the pandemic. But other viruses could definitely cause a pattern like this. So any of the HHV, HIV, hepatitis, and so on. The leukocytosis, though, is significant, and bacterial infections do come to mind. But to this degree, I can't help but think of any number of lymphoproliferative disorders, maybe leukemias in this case. So it could be anything from CML, AML, I think we would need to get more information and maybe consider exploring this possibility. But those are a few things that come to mind. Again, there's a vast number of infections that can present with lab data like this, namely viruses, and then with such an elevated white count, definitely leukemias. Again, going back to lytic lesions and trying to marry this to these lytic lesions, again, malignancy does come to mind. I like the thought about sarcoidosis and its manifestations, but the labs I don't think really helps me to dwell on this diagnosis and drop my diagnostic anchor. But then let's see. Oh, I think we have an issue with the white count. Is it 2100 or is it 2.1? Because that definitely changes things.
No, 2. Wait, now I got confused. Sorry. It's no 2100.
Okay, 2100. Okay, okay. So those are a few things I'm thinking about, but let's see, is there one more aliquot before the final diagnosis?
Yeah.
Oh, Pierre Nasir has mentioned, yes, the bibasilar crackles. With sarcoidosis that Ketan had mentioned, that can definitely target the lungs. You have mediastinal adenopathy. You have crackles, so sarcoidosis can manifest in 4 different stages. Primarily, you have the bilateral high lymphadenopathy, or you have lung involvement and the inflammation or fibrosis. And then you can have, I'm forgetting the 4 stages, but there's the BHL, the lung involvement, and the combination, and then just the lung involvement by itself, if I remember. But this could actually make that more likely. The papillary squamous, just mentioning that, yeah, that can also manifest with sarcoidosis or any number of conditions that he discussed. But I'm very interested to see what the next aliquot reveals to us before the final diagnosis.
Okay, so the ID was consulted and was recommended alpha-terracing for presumed blastomycosis, and then was recommended to repeat the bone biopsy and a skin biopsy. And the patient had been proved with the amphotericin B and was discharged with itraconazole, and the next aliquot with the bone biopsy will reveal the diagnosis.
Right. Thank you so much for sharing that information, Deborah. So I think now we can see that how our thought process evolved during the case, and how having a broad differential upfront kind of helps us narrow the things down when we reach the terminal end. So like when we had the lytic lesions and when we had the cutaneous eruptions, we are thinking about granulomatous infections. So we mentioned that could this be tuberculosis? Could this be endemic mycosis? Could this be leishmaniasis? And then could this be brucellosis and things like that? And now we have more evidence to support that this could be indeed disseminated blastomycosis. And what are the risk factors for that in our case? So our patient has HIV infection and the CD4 count was low, although the viral load was undetectable. But we know that sometimes even in people who have undetectable viral load, if the CD4 count is in that range, and histoplasmosis and blastomycosis are some of those infections which do not follow clearly the CD4 guidelines, like we think that, okay, CD4 is less than 50, you will get this, you will get that. But then there are some infections like TB and this blastomycosis, which can come at any CD4 count. So even if the CD4 count was normal, we should consider the disseminated fungal infections. Disseminated fungal infection usually involves the bone marrow as well. That's one of the hallmark of blastomycosis and histoplasmosis. So which can explain the lymphopenia which we have, although the contribution of HIV to the lymphopenia itself cannot be ruled out. The lytic lesion part, again, just like tuberculosis, all the endemic mycosis have propensity to involve the bone, so which can explain the findings which we have. And the cutaneous eruptions. So this is something we used to learn when we were in med school, that endemic mycosis, when you have the disseminated infection, so what are the things that they involve? So they involve the bone, they involve the skin, and in people, in like males, it also involves the prostate. Classically, it causes prostatic abscess and prostatitis, like chronic prostatitis. And in the females, it can sometimes involve the genitourinary tract, rarely, but more likely meninges as well, especially with coccidioides. So that's the script for disseminated infection. And the crackles in the lungs, which we had, so that can also go along with our thinking, because all these infections can involve the lungs, lower lobes, upper lobes, middle lobes. They can cause reticulonodular infiltrates in the lung. They can sometimes even cause pneumonitis, interstitial pneumonitis, so which can explain the crackles which we had. And in the neuro examination, we forgot to discuss about the lower extremity strength, which was 2 out of 5 in the left side. So that again raises the suspicion that is this because of the nerve root compression which was going on because of the involvement of vertebral column, or it was because of the femoral lesion which we had, and that is causing the localized nerve impingement of the lumbosacral plexus. So I think we have some conclusive evidence that this could be blastomycosis, and hopefully bone marrow biopsy will reveal us the classic morphologic features like broad-based budding. But last thing I would say that, anchoring bias, we always say that maybe some left findings are there and then you jump to the diagnosis. So although itraconazole, we have prescribed to the patient to be on the safe side, and hopefully the patient will improve. But if it doesn't improve, then we should, take a step back and think about other possibilities that we discussed before this blastomycosis result came back. So Dr. Singh, what do you think? How we should approach it finally?
Oh, I absolutely love you for explaining the illness script for blastomycosis. Yeah, it's kind of difficult. I guess if in the stem we talked about histoplasmosis, the geographic location, if Deborah had mentioned Ohio River Valley, would trigger, I guess, system one thinking this would be a buzzword for blastomycosis. Also, interestingly, has one other name linking to Kirtan, Chicago's disease. I don't know if you knew that, or Gilchrist disease. And it definitely has a presentation of a multi-system disease. So like you highlighted, all the different systems that can be affected. But it's very difficult at the beginning if we think about our thinking, that were we convinced that it was something, we kind of did explore this domain, but there was nothing really standing out to us. Yes, the patient is immunocompromised, like you said, that puts the patient at risk. But and as somebody had mentioned, that it is acquired initially through the lungs, hence the crackles. So what I do remember that it can manifest from anywhere from simple inflammation, pneumonitis, to a pneumonia, to ARDS. So it can be quite devastating in some presentations. It does, I guess the answer did lie in the bone. So it's necessary when you do a biopsy and there is no answer, to possibly repeat it again, because when you put the needle in, you may put it into, because you are kind of going in blind, you may be doing it under fluoroscopy or some imaging guidance, but you actually may miss a part of the bone where it may have the broad budding yeast, as you mentioned, when you do obtain the sample. So it's very important not to discard your initial suspicion that there could be fungal infections involving or causing this. And if you get a biopsy, it's not the end of further working that up, but you may have to repeat it again, or maybe do a more invasive intervention like surgery and getting a larger sample to determine if this is an infection or not, or a malignancy like we had discussed. I'm not sure if with this case doing a 1,3 BPG, any of the fungal markers would help. That could maybe heighten our suspicion for maybe a fungal infection, but they're not definite. They're not 100% sensitive there or specific for fungal infections, but it sometimes could help maybe narrow your focus in the domain of fungal infections. But I would have to take a look at that. Anything else back to you, Kirtan? Anything else comes to mind before
No,
we get
I
the
think I
final
agree
DX?
with you. I agree with you, Dr. Singh, that although we are suspecting blastomycosis, but of course we should keep the mind open and don't anchor to it. And hopefully bone marrow biopsy will show us the answer. Back to you,
Awesome,
Deborah.
awesome.
Great discussion, everyone. So yeah, the bone biopsies show numerous non-caseous granulomas, and the patient was diagnosed with sarcoidosis. And I'm looking to you all faces. And then they checked the chest X-ray and had like some periolear fullness, and then she passed for a transbronchial biopsy, and then had like some multiple non-caseous granulomas in her lungs too. And some pearl that I saw in this case, like in addition to have like the concern for atypical infections, sometimes in patients with AIDS, we have to look for atypical presentations for common inflammatory and autoimmune disease. So yeah, thank you, everyone. It was such a great discussion.
Dr. Singh, do you want to share your thoughts first?
Deborah, that was amazing. Holy cow. We went suddenly from blastomycosis and really being sure that it was that, and to back to sarcoidosis. I mean, the sarcoidosis, blastomycosis, sarcoidosis again, but holy cow, there's no hypercalcemia. There's no hint of it except just a high suspicion. And we talked about this lupus pernio. You can have Lofgren syndrome, some unusual presentations. This is very unusual. I'm not sure. Anything, Kirtan, from the beginning that really definitely increased your suspicion for sarcoidosis?
I agree with you, Dr. Singh, that, with sarcoid, there is always this confusion because we know that it's a diagnosis of exclusion. Like the case which I presented about a week ago to Ravi, that the patient presented with like mediastinal adenopathy, the nodules in the peritoneum, and the biopsy did show the non-cascading granulomas, but then in the end, it was indeed tuberculosis. So the thing with sarcoidosis is that once we commit to the diagnosis of sarcoidosis, and if the patient is symptomatic to this degree, there is no way that you wouldn't start the patient on steroids. You definitely start the patient on steroids. And the moment you start patient on steroids, things go haywire if it's infection. Like if it was indeed like blasto, histo or something, then the patient would certainly be in a terrible state when the patient comes back. So that's why often with sarcoidosis, we have this inertia that, well, is this really sarcoid? Maybe I should give just in case, this fungal therapy or maybe anti-tubercular therapy. And then later on, maybe 3 months down the line, I would start the steroids if things don't pan out well. So I think that's always a conundrum when we deal with the sarcoidosis. But looking back, always when we had the right degenerative adenopathy, we discussed the nice differential that could this be histiocytic disorders, could this be autoimmune disorders like sarcoidosis, and could this be infectious disorders. So at least we had that approach. And then even with the cutaneous eruptions, we were, kind of thinking that, oh, could this be lupus pernio, like the erythematous lesions and things like that. So that is important. And the last thing which I have learned from almost all the medical journal cases, that they always mention this anchoring bias. Like you think that, okay, patient was started on itraconazole from, let's say, outside hospital before being referred to your hospital. And then you immediately think that, well, if the outside hospital suspected that this patient has blastomycosis, why don't we just continue the itraconazole and then discharge the patient home? So there is always that thing that, okay, if the diagnosis has been assigned to the patient, then we should move ahead with the diagnosis. But at least in this case, we had the suspicion that, okay, this could be blastomycosis, but let's see what the bone marrow biopsy reveals. So I think having that anchoring bias point in our mind helped us so that we just don't commit blindly to that diagnosis. So I think this is a really nice case. And in the future, I would always think that consult a dermatologist if you are not sure, and then think twice before jumping to the diagnosis of some infection.
Yeah, while you were talking, it did trigger a couple of thoughts. Like we had a case a while back of GPA manifesting with papules and so on. So you can be tricked. But now reflecting back, mediastinal lymphadenopathy, these crackles with sarcoid, usually the lungs, are quite central to this process. Would, if Deborah gave us an ACE level, would that have helped us? Yes, it's not sensitive or specific, so we really couldn't invest a whole lot in that if it was negative. A lot of times it could be negative and it could be a detractor. But yeah, I was like sidelined by that response to the antifungal therapy. And that really made me sure, like, this has to be a fungal infection. But many times we see, even with antimicrobials, if there's a resistant organism, the antibiotic that the organism may be resistant to sometimes can actually put a lid on the inflammatory response of the infection. So patients may feel better, but they're not going to be cured by that antimicrobial because of resistance. So for some reason, the antifungal exerted some anti-inflammatory response and the patient may have responded, but this is temporary. The patient's not going to be cured. So in fact, if you discharge the patient, they may come back, maybe worse off. So it's imperative to not just ignore or have premature closure, but to work through this to see if this is the correct answer. So again, it's a great walkthrough of sarcoidosis and also a great way to think about our thinking. So I appreciate this, Deborah, and really appreciate it, Keithan, for co-discussing today. And who do we have doing teaching points?
Yeah.
Oh, yes. Oh, Yasmin. Okay, thanks.
Yes, amazing case, Deborah. We got the biggest plot twist. It's always great to listen to Dr. Kirtan and Dr. Ravi discuss. And for teaching points, our main approach of the leg pain first, we have to assess the equity, the unilateral, bilateral, if it could be referred, or even be wary of compartment syndrome. Think of the main issues that can cause leg pain and if they are cured or not. Also, Dr. Kirtan made a great characterization, how to look for, like, systematically assess the leg pain. Could it be vascular? Could it be due to skin infection? If there's rash or petechiae, the bone, osteomyelitis, septic arthritis, muscle, it could be a infectious or autoimmune myositis, and even determine if the nerves could be impinged or if there is an infectious neuropathy that can cause pain, thinking that our patient is immunocompromised. Now, lytic lesions made us think of malignancy, where myeloma, osteosarcoma, and even METs can cause these kinds of lesions in the bone. Now, we approach the mediastinal adenopathy, where Dr. Kirtan said that myeloma is one of the malignancies that does not cause lymphadenopathy. Other diseases that can cause it can be sarcoidosis and systemic mycosis. We jumped into the papillosquamous eruptions, where infections such as mycosis, syphilis, leishmania, brucella can cause this type of eruptions, without forgetting that there are also autoimmune diseases such as sarcoidosis and histiocytosis that can cause them. Where the lymphocytopenia made us think about the viral etiology of this, of the cause of this disease. And as well, don't forget that HIV can cause bone marrow defects. And to end with blastomycosis, we thought it was because of the geographical situation of our patient, but doesn't see a part. We thought about the cutaneous blastomycosis can start as papules that can evolve into crusted flakes, and also characterizing this granulomatous disease got us to the conclusion that we have to be aware of the anchoring biases when the doctor repeated the bone marrow biopsy and found these numerous non-caseating granulomas, taking to the final diagnosis of sarcoidosis. And these are all the teaching points for today. Again, thank you. It was an amazing discussion.
Thank you, Yasmin. That was absolutely wonderful. And thank you, Deborah, for a brain twister of a case. Appreciate it. Definitely will read through back on sarcoidosis. And Keithan, thanks for coming on again. And thanks everybody for coming on, and I hope you learned a lot, and see you tomorrow for another VMR. Take care.
Take care. Thank
Bye.
you.